Australian COVID numbers surge. Will they bring back restrictions? Let's have a look. Hello everyone, Florian.heise here, and welcome to another episode of HeiseSays. Grab your stein of coffee, and I thought, as my last video of 2021, we'd look at the surging COVID-19 numbers that are happening across Australia, and an organisation that's pushing for, well, a restriction or bringing back restrictions and a removal of the scaling back of government and health interventions. Great way to end the year, everyone. So in Queensland, in the past 24 hours, we've had 3,118 new cases. We've got now over 11,697, with the total cases to date of 13,863. 64 are hospitalised, 1 in the ICU, and 7 lives lost to date. Over 2,153 have recovered. So you can see we're finally starting to get the virus here in Queensland. We've been very fortunate that it hasn't really manifested much here, but it's, considering Omicron appears to have less of an impact, we may be lucky. New South Wales, they've had over 148,000 tested in the last 24 hours. They've got 21,151 new cases. 832 are hospitalised and 69 are in ICU. They've had 6 deaths. And if we have a look here, in Victoria, they've got 428 hospitalised. They've had 5,919 new cases, 7 lives lost, and 28,000 active cases. If we have a look here at South Australia, this is from their COVID dashboard, everyone. New cases today, or yesterday, were 1,374. They've got 7,561 active cases, 8,993 total cases, 37 are in hospital, 4 are in ICU, and over 1,426 have recovered. They've had 6 deaths, everyone. Now, here's a heat map showing you where it's happening in South Australia, and you can see the daily cases are just skyrocketing. They've had no pandemic really in South Africa. Now it's, South Australia. We'll talk about South Africa in a moment. But now there you go, it's skyrocketing up. And cases confirmed by age, you can see it's a big spike in the 20 to 29-year-olds, probably the people that are out there partying and enjoying the city. And it seems to be fairly even. Oh, wait, no, the women are leading the way. There you go. And there's the daily tests. Look at that skyrocket. And this is the source of infection, close contact. Locally acquired, interstate, and under investigation in quarantine. And this is the source of the infection, as we said. Expiration issues, yep. So there you go, everyone. South Australia, New South Wales, Queensland, and Victoria are really, hitting it hard, guys. And let's have a look at South Africa. Now, the reason why I want to look at South Africa is because this is the first country that reported Omicron variant, and that's essentially replaced Delta. They've removed a lot of restrictions, guys. There's some suggestions that Omicron may become endemic, and the impact on people is going to be significantly less than other illnesses. Now, we just need to have a look here. Okay, this chart is showing you here, this is weekly cases. Okay, and this here are weekly deaths. Now, here's the first wave. There's the deaths. There's the second wave. There's the deaths. There's the third wave. There's the deaths. And notice how when you got the peak, it's about a 2-week delay. This is the Omicron wave that we're seeing here. And this is the beginning of that deaths. Now, look how high it is. Look at that. Sure, that's a 2-week delay. So what do we go back? Boom. We're seeing that number right now represented here. Okay, and look at this back here in the third wave. There we go. So almost a factor of, what was it, a factor of 10? No, not quite. Not quite. 2,900, so it's 3,000 as opposed to 4. So, 6 times higher, everyone. Have a look here at the vaccination rates. Okay, the vaccines are working and mitigating this, one could at least argue. And there's evidence as well to back that up. But let's have a look here at, a report that's been released yesterday from AussSage. And who are AussSage? Okay. Is a multidisciplinary network of Australian experts from a broad range of sectors relevant to the well-being of the Australian population during and after the COVID-19 pandemic. AussSage formed in response to the current Australian epidemic. Meeting for the first time on August 16th, 2021, in the midst of many competing expert opinions, AussSage offers well-researched and robustly debated independent expert advice. We do this to inform the common national goal of achieving an exit strategy from this pandemic with the best possible health, social and economic outcomes. Members of AussSage are not paid and provide their time without remuneration and without a political agenda. So what we'll do is we'll look at the members list. Members have experience, expertise and frontline roles in public health, infectious disease, virology, immunology, epidemiology, vaccinology, clinical disciplines, intensive care. What do we have? What else? Mental health, Aboriginal health, engineering, built environment, occupation, hygiene. Are there any economists? Oh, there we go. And economists there. Here's the list. So we can see here, Professor Nancy Baxter, Public Health Oncology, Professor Margaret Heller, Professor Rich Holden, Professor Lisa Jackson Pulver, Professor Greg Kelly, and the list goes on. You can go through all of these people here who are contributing to this. And let's have a look at their report of what they're saying, because it's going against some of the more optimistic narrative that we're seeing around, because there's people who are still terrified. You can see it on Twitter, you can see it, some of the really sad stories. People are terrified of this. Maybe we just need to start teaching stoicism in school, everyone. So, AussSage remains deeply concerned about COVID-19 in New South Wales, which is already affecting all of Australia. We commend the New South Wales government for reinstating mask mandates and QR code check-ins. I think they're getting rid of QR code check-ins again. I mean, the QR code check-ins, are they even working, everyone? The decision to remove restrictions just as Omicron surged has cost us dearly. Has it? We haven't really... What's the cost? We now have over 12,000 cases a day in New South Wales. Okay, now I will reference at the end of this video another video with a preprint of research coming out of South Africa saying that Omicron increases your immune response to Delta and other variants. And Omicron, well, because it's so infectious, it surpasses Delta. So if you've got a vaccinated population, which we have, over 90%, people catching Omicron is actually going to be a benefit to them with regards to catching Delta in the future. Okay, now that research, it's just new. It hasn't been peer-reviewed yet. It's been accepted. We have to see if it's replicable. But we can't necessarily claim that this is going to be a negative cost if it could be a benefit. But I can see where they're going for it. I mean, this is the thing. They're just measuring cases. A testing system that cannot keep up with demand, and a health system so burdened that citizens are being told they may not be able to access healthcare. Is it really? Look at the hospital numbers, guys. We just had a look here, okay? Where are we? New South Wales, 69 in ICU. They've got 832 in all of hospital. Let's have a look. Number of ICU beds. So here we have the intensive care capacity, at least from September 2021. And we can see here ICU demand and capacity modeling. And I'll link to this if you want to go through it. The total estimated peak hospitalization includes COVID and non-COVID demand, and also include ICU bed. Total estimated ICU, peak ICU occupancy includes COVID and non-COVID at 945. Estimated peak COVID ICU demand is 560. But if we scroll down here, we can see, surge capacity is 1550, everyone. Okay, so we are not anywhere near that at this stage. In New South Wales, they've got, under 70 people in ICU for COVID. Now, this is the thing. This is the concern with COVID. Reality is that it can impact ICU more than other illnesses because your length of time in there is much longer. That's the problem. That's why we're seeing these insane responses, because that's what they're afraid of. Because you can pass the illness on being asymptomatic, not even know it, and then the whole health system could collapse. And it won't be the people just from COVID who won't be able to get any treatment. It'll be other people going to hospital that won't be able to get any treatment. But we'll have to see, guys. Staff stand-downs will continue to escalate and affect more and more people. This includes supply chain logistics and every part of civil society. All models to date assume good testing capacity and adequate contact tracing. Without these, case numbers will blow out further. At this point in time, there is no publicly available modelling to support a national plan that is based on public health principles, which will protect our hospital system from collapse. Now, this is the concern, because they don't have the modelling. They're expecting that it'll collapse, or they're concerned that it'll collapse. I mean, that's a reasonable assumption. You don't want it to fall over, do you? But what if it doesn't? Why aren't we looking at other countries? Why aren't we looking at the research coming out of South Africa? I'm sure they have. So, testing disaster. Testing in New South Wales is failing, with many people turned away after waiting in queues for hours and many testing centres shut. Regional and remote areas have even less capacity. There are unacceptable delays in testing results being sent. Worse, there have been greater than 1,000 infected people who were sent a negative test result by mistake. And this problem has not been addressed in a transparent fashion. Yeah, I mean, this sounds like the whole testing is a complete and utter nightmare. Rather than investing in expanding testing capacity, the response of government is to restrict access to testing by changing the definition of close contacts and allowing PCR tests to do only family contacts, health workers and a few other groups. This will reduce our surveillance capacity for new variants and give falsely low case numbers. In addition, the test positivity rate is 13% in New South Wales compared to greater than 2% during the Delta wave, telling us we need more, not less testing. People are now being urged to avoid testing centres and hospitals and to do their own rapid antigen tests that cost between $12 and $20 or more for a single-use test and are unaffordable for low-income people and families. Given the need to test multiple times during the pandemic, there is a severe shortage of rats nationwide. This means even people who can afford them and could relieve the pressure on the laboratories simply cannot buy a rat kit. We commend the Victorian government's announcement of procurement of rats to distribute free of charge to Victorians and the federal government's announcement that they will co-fund the provision of rats with states. Rats are useful for screening of asymptomatic cases but cannot serve as the backbone of the public health and test and control systems. The results are not reported to the government, so people who test themselves and self-manage the COVID-19 will not be counted in our official case numbers. Yes, this is what we want, everyone. We want people to move away from having to be a burden on the laboratories or on the state at all. We want people to self-manage this from home. That's the future we aspire to. I thought that was the goal. But of course, that's a little bit too much freedom that these people don't trust you with. Are you noticing that? I mean, the fear in here. Then there is unknown reliability of individual rat brands with the Omicron variant. As a nasal swab, the usual method is less likely to be positive than a throat swab. There's been no messaging to advise people on swabbing both the nose and the throat when doing a rat. There should still be a requirement for a PCR test after a positive rat. I'd rather do a throat swab than a nasal swab, to be quite honest. I've never had to do a test. So, we're disturbed by the repeated messaging that only symptomatic people should get tested when 40 to 45% of transmissions are asymptomatic. And, well, that's because if you're asymptomatic, if you're not even noticing any symptoms, are you at risk of needing hospital services? This is the thing. We're moving away to an endemic where this is just going to be like the cold. And it's going to be hard for some people to make that transition because they're going to fear the worst because these are healthcare professionals. That's their training. And even in people who develop symptoms, the peak of infectiousness is at 2 days before symptoms begin. The false reassurance of the messaging will result in more cases of viral transmissions than otherwise would have been prevented. So who is a close contact? We have previously outlined the importance of contact tracing and QR codes. The proposed change to the definition of close contact is to reduce testing and resources and is not based on sound public health principles. Close contact definitions need to be based on risk. Risk is related to the amount of exposure to virus-laden aerosols. Risk is not limited to arbitrary 4-hour time frames within households. Settings like nightclubs and restaurants have been sites of super spreader events, and if people exposed to these settings cannot get a PCR test, spread will accelerate. Well, is that what they want? Case numbers matter. It's simple maths. The rhetoric that case numbers do not matter is incorrect, particularly in the face of the Omicron variant. Daily case numbers are now 10 times higher than during the Delta wave and may be 100 times higher in January, even if hospitalization rates are lower. And remember, all of this is coming out now when we're sitting over 90% vaccination rates, guys. Okay, just remember that. Even if hospitalization rates are low with Omicron compared to Delta, a halving of hospitalization rates with a 10-fold or 100-fold increase in case numbers will still translate to a high burden on the health system, but we're not seeing that. I just showed you the numbers from South Africa. There, at least from the deaths, okay? And if deaths equates to hospitalization, are we seeing a halving of it there? Look at the case numbers here. Look at New South Wales. Look at Queensland. Hospitalization rates are not halved. They're much lower. I mean, so there you go. There's the daily case numbers, there's model, and there's the actual. Does anyone even trust the modeling anymore? Hasn't it been proven that the modeling's been wrong again and again and again? You can make any assumptions to model what you want. So look at there's the modelling, there's the ICU. There you go. There you go. We'll have to see. So there's the actual, there's the modelled daily case numbers. A basic queuing model of hospitalisation and ICU occupancy rates shown above, fitted to New South Wales Delta outbreak of the July-October 2021, indicates that hospitalisation and ICU occupancy rates are now smaller fractions of reported case numbers than they were during the Delta outbreak. However, the trajectory of observed data suggests that the hospitalisation and ICU occupancy are on a steeply rising. Yeah, they are, but nowhere near where you've modelled it. Look at that case numbers. Look at how sharp that is. That's nuts. Anticipate to exceed earlier peak quite soon. Yes, but look at that peak load there, guys. We're still nowhere near the surge capacity in ICUs. So should we worry? Here's the question. Should we intervene as much as we have into the economy, restricting our freedoms, when we've got buffers? When we've got such high immunization rates? And, I mean, how difficult is it going to be to make a shift? It's not going to be easy for people to shift away from a mindset of control, protection. It's never going to be to a point where they're willing to potentially risk lives because they've been hard-coded to not do that. There's the question. I mean, where's the risk assessment? When do we loosen the strings and give people freedom? I mean, if we're letting people die to install fat bats so Labour can win an election, yeah. So, in other words, optimistic assumptions about the impact of the Omicron variant on hospital admissions are unrealistic. We don't know yet. Remember, if the daily case numbers here are completely even higher than what you're thinking, because no one at all the asymptomatic people, if it goes right up to here, then, that percentage of the actual cases could be quite lower than you anticipate. So they're taking that into account. So introducing a narrower close contact definition when the test positivity rate is currently 13% in New South Wales is unlikely to improve the burden on the healthcare system and will instead fuel the outbreak. Limiting the amount of testing results reduces pressures on the test and trace system in the short term, but will worsen the health system burden because it will result in chains of transmission that could otherwise have been stopped. Over the long term, these quick fix adjustments for resource reasons and better optics will be detrimental. Remember, they're meant to be apolitical. Does it feel like it? So Omicron is less severe than Delta, but similar to the 2020 virus. Really? Doesn't look like it. Not with these deaths. We'll have to wait and see, guys. Doesn't look like it at all. What's this based on? Where's the references? The intrinsic virulence of the Omicron variant remains unknown and is challenging to establish due to the differences in population makeup, the effects of vaccination programs, and prior variant exposure across countries. Now, that's true. Preliminary data suggests that compared to the Delta variant, Omicron infections are 40 to 45% less likely to result in hospitalizations. However, the Delta variant was significantly more virulent than the original strain of the virus, being at least twice as likely to lead to hospitalization or death. This means that the Omicron variant is at least as virulent as the original strain of SARS-CoV-2, with far greater vaccine escape, and cannot be described as mild. In the US, we have seen rapid increases in hospitalization in children. As the virus moves into vulnerable populations such as older Australians, people with disability, and Aboriginal and Torres Strait Islander people, we may see a rise in hospitalization and death, as has been observed in countries such as Denmark, which are a week or two ahead of Australia in the Omicron surge. Okay, let's jump here. Let's have a look at the Johns Hopkins. Let's look at Denmark then, guys. Okay, a week or two ahead. What are we looking at here? Netherlands. Wait, no, Netherlands. Denmark. I'm thinking Holland, aren't I? Okay. They've had, in the last 28 days, 269,000 cases. Deaths in the last 28 days, 338. Total cases, 783,000. Total deaths, 3,200. So where is, let's have a look at their, hang on, we'll bring up Denmark. Here we go. Okay, we can see here, this here, okay, this is the middle wave. They didn't really get much in July, but look at that peak of deaths there from so few cases, guys. So few cases. There's the, look at that, quite high. Okay, now they're a few weeks ahead of us. They've got 111 deaths, okay, and that's from 45,000 infections, everyone. So they're rising up. The immunization is going higher as well, as we can see. Let's have a look at their incident rate. What are they sitting? So 13,500 per 100 people. Case fatality ratio. Come on. Come on. These dots are so small. 0.41. 0.41. So still pretty low, everyone. But here's the thing. If we've had, how long have we been with this bloody pandemic, guys? Where is the, I mean, sure, we've got surge capacity with ICUs, and we've got other facilities that we can use. Why hasn't that been improved? Where are the plans for that? So, chronic illness from COVID-19. We know nothing yet of the incident of long COVID associated with the Omicron variant. During the first wave in Sydney, 1/3 of people with mild to moderate COVID-19 were left with persistent symptoms, including shortness of breath and fatigue. Long COVID could impose an enormous economic and human costs on the Australian health system for years. Yeah, but so does diabetes. And we let people eat shit all the time. So does, heart disease. And we let people, smoke and all this other crap all the time. Whoop-de-doo. Okay? It'll keep you employed. New research from the US shows the virus persists in the brain, heart, and kidneys, and many other organs long after the initial illness. So preventing disease now may prevent long-term chronic illnesses. We also know that in Australia and overseas, pandemic surges have prevented the access to care for cancer diagnosis and treatments for heart disease, strokes, and trauma. This has resulted in excess deaths for non-COVID illnesses. But wasn't that because they forced everyone to stay at home and the hospitals shut down those services? So it's not really COVID-19 that did that. It's the responses to it that did that. So, lack of access to healthcare and death at home. Our health system, stretched before COVID-19, has had its capacity eroded by staff resignations and a blowout in waiting lists. Further impacts on the health system by the sheer number of Omicron cases at this time of year especially could be enormous. The rapid rise in Omicron cases may mean we're only days away from seeing higher hospitalizations and ICU admissions than during the peak of Delta. Well, Denmark didn't. Case numbers, whether formally recorded or not, will continue to climb until an adequate vaccine plus strategy is in place. A person who has been hospitalized for COVID-19 is no longer counted in the hospital statistics once they cleared the virus, even if they still require a high level of care. Therefore, the true number of hospitalizations for COVID-19 related disease accruing in the wards and ICU is not transparent to the public. Okay, the number in hospital for the home or in the waiting list for services is not transparent to the public. We will also note that pediatric admission to hospital in the home, wards and ICU are accruing. We note that the shortage of staff is such that they are now asked to work after shorter isolations, and there is concern for burnout and fatigue. New South Wales recognises the overload of the hospital system and is already warning the community not to expect access to hospital care. 1 week ago, New South Wales Health advised people under 50 to care for themselves at home without access to hospital in the home. This week, they have revised the age cutoff to anyone under 65 years. This is the ultimate impersonal responsibility, where citizens are left without access to healthcare and to sort out their own COVID care, as well as to do their own contact tracing while sick with COVID-19. Consideration should be given to support for people found COVID-19 positive who are in caring roles. The consequence of this policy is that many people die at home when their lives could have been saved by proper, timely healthcare. Without the safety net of regular contact from medical services, the unintended consequences are likely to be more ambulance call-outs and emergency department presentations. AussieBroadband tracked reported deaths at home in New South Wales during the Delta wave and found that there were a disturbingly high number of deaths of relatively young people with COVID-19 at home between July and October 2021. During the Delta wave, we calculated the mean age of people dying at home from COVID-19 to be around 40 years of age, with some in their 20s and 30s based on public reports from New South Wales. During any other time, this would have been a national scandal, but it passed without comment or scrutiny from policymakers and health authorities. Or wasn't the reason a lot of them were not trusting of the government? We remain deeply concerned that people with preventable and treatable complications of COVID-19 may die at home in New South Wales without access to even the support of hospital in the home. If there is a wave of bed block, forced palliation in the home, and the lack of any mass population planning for this means people could have survived with hospital care may die of COVID at home without any palliative care support to ease suffering. So GPs are expected to step in for failing hospitals. The health system crisis response has been to ask people with COVID to self-care at home and call their GP if worried, rather than coming to hospital, at a time when many GPs are in hospital or running skeleton services. This enormous surge in demand for GP services has not been funded or supported. Much of the palliative care burden will fall to GPs, as the hospices will not have capacity to manage people dying of COVID-19. Okay. We've had 6 deaths in New South Wales, everyone. 6. 7. Okay. We have a look here. Let's to Australia. Overall deaths in the entire country are 2,233. It's tragic that people are losing their lives. But this doesn't seem as much out of 368,000. And then if you look at the age breakdown, but okay, 6 a day, 7 a day, surely we can manage that in our healthcare system. So, anyway, back to this. The enormous surge in demand for GP services has not been funded. Yeah, but they get Medicare anyway. GPs also have to cope with the surge in demand for vaccination for 3rd dose boosters and children 5 to 11. Self-care and home patients should be supported through GP Medicare funding that recognises the unique complexity of service delivery and coordination required through adequate additional MBS items for GPs and nurses, including telehealth and telephone services. That's a good idea. We need to have more of our healthcare services provided remotely. I mean, here's the thing. I wanted to get an antibiotic. I found out, I'd injured myself and I was getting infected, so I looked up what I needed to get. I could have done it all myself. But, here in Australia, I need a doctor to write me a script so I can get access to that. I understand why they're doing it, but perhaps we need to move away from that, reduce some of the doctors' roles, maybe allow pharmacists to prescribe medication directly for certain things like that so people can manage their own health. Treat people like adults, guys. Shocking idea, isn't it? So changes in recommendations for boosters won't get them in arms. We understand the National Cabinet is reviewing work isolation quarantine times in order to address the apparent staff shortages across critical health, first responder, and essential worker. This may worsen infection of essential workers. So changes in recommendations for boosters won't get them in the arms. Yep, 2 doses of vaccine provides a minimal protection against Omicron and wanes rapidly against Delta. While the changes to ATIGA guidelines for bringing forward the timing of boosters from a minimum of 3 months from January 31 are welcome, the lack of urgency in delivering boosters will allow both Delta and Omicron to spread. In Victoria, state-administered vaccines have fallen dramatically, despite the need for urgent action. During the holiday season, when people are travelling and mixing more, there is a need to ramp up the messaging and delivery of boosters to control transmission of COVID-19. A fatalistic approach will be fatal for some people. That's life. Okay? That's life. People die. It happens. Sometimes it's avoidable, sometimes it's not. It's sad, but it's life. We want to get back to normal life. We want to get back to existing. The let it rip strategy and defeatist narrative that we're all going to get it, well, yeah, we are, ignores the stark, lived reality of the vulnerable of our society. Despite 3 doses of vaccine, some patients with cancer and other immunosuppressed people have substantially reduced protection against Omicron. Similarly, people with no coexisting health conditions, estimated to be 50%, with coexisting health conditions, estimated to be 50% of the adult population, are at increased risk of illness. The impacts of a fragmented testing system and disruptive health system will be felt mostly by our elderly, lower socioeconomic groups, First Nation people, people with disability, and regional populations. We must keep public health measures in place to protect these populations and ensure no one is left behind. A fatalistic approach will be fatal for some people. AussieBroadband is deeply concerned that children who are unvaccinated are completely unprotected. Already a 10-year-old has died in New South Wales. Children's hospitalizations are increasing in both the UK and USA. The failure to make school and childcare centres safe from aerosol transmission of COVID-19 must be immediately addressed as we have outlined already. So, recommendations. Let's see what AussieSays are recommending. New South Wales Health should immediately conduct a transparent and open investigation into why a private pathology provider issued falsely negative test results to infected people and provide a solution to prevent that happening again. Yes, great idea. I agree. 100%. The federal government should procure adequate rat supplies for Australia and make them free, or at least subsidise the cost for all Australians. A national notification system of positive rats should be developed. What do you reckon? I don't like the idea of the government. Anything the government does for free, we're all going to pay for anyway. So how do you want to pay for the rat test, guys? Do you want to pay for it as you need it, go to the Officeworks and pay $40? Or, pay for it in your taxes? You pick. And you want to be forced to report it to the government so they can track you. People are bitching and moaning about using a QR code that no one knows. But what about that? So disseminate information to labs in the community about the need for nose and throat swabs for detection of Omicron. As nasal swabbing alone is less accurate, most rat tests are for nasal swabbing. Yes, I agree. That makes a lot of sense. 100%. Governments should avoid misleading messaging that tells asymptomatic people they do not need to test. Anyone who has been in close contact should test regardless of symptoms or location of the contact. Okay. You can't be bitching and moaning about not having enough tests and tell everyone to test. Okay, you're already going to get the hypochondriacs that are going to test every bloody time. And now people who are asymptomatic, who don't even know if they have it, who may have been in close contact, you want them to test too. Come on. You can't have it both ways. You can't have it, or probably in this world, they want to have it both ways. But we've got limited resources. Which you want to pick? Pretend you're in triage. Prepare surge health workforce capacity as per previous AussieSays advice. A fit-for-purpose model of hospital in the home and a palliative care plan should urgently be implemented in all states to ensure adequate health care for COVID-19 patients who cannot access hospital care. Leaving infected people without guaranteed access to a pulse oximeter or even telephone advice is unacceptable. We recommend additional funding for the provision of pulse oximeters to all people self-caring at home, or people could just buy it themselves. Okay, just go out there and get one yourself. Spend your own money, everyone. Okay, come on. Procure oxygen supply to deal with the Omicron surge immediately. Medical advice and current modelling that forms the basis of a state or national COVID-19 response should be publicly available. Yes, 100%, that should be. Transparent reporting of infected people self-caring at home, hospital and home, as well as wait lists should be routine, along with hospital ICU numbers. Yep, fantastic. Deaths at home should be monitored and reported weekly, with an age breakdown as an indicator of failure of the health system. Yeah, no, good. Ramp up delivery of booster doses at all facilities immediately as per our previous advice. Create new COVID-19 GP management at home, MBS item. Okay, Medibank. Yeah, I guess. Or Medicare. Immediately reinstate MBS telehealth items, numbers, and remove hotspot declaration. Yes, 100%. We just need to have that as a permanent part of our healthcare system now. Okay, you want to reduce the need for people to even go to hospital. Immediately review the vaccination ordering system for general practices and remove fortnightly allocation limits to allow general practices to order the amount of vaccines they can deliver. MBS schedule should be adjusted. Okay, yeah, that makes sense. That makes sense. If isolated quarantine times are reduced, we recommend that the reduction be no less than 7 to 10 days, depending on the risk balance for the workforce industry, alongside a program of funding and testing and respirator to reduce spread. Education to overturn the we're all going to get at messaging and enable the public and businesses to use simple prevention measures. This requires consistent national messaging on masks, on vaccine masks, and safe indoor air. Okay, so there we go, everyone. There we go. COVID numbers surging here in Australia. I want to read their thing on safe indoor air. We might do that in another video because this has nearly been a half-hour video, guys, going through this AussieBroadband report. What do you think, everyone? Are you concerned or are you worried about what's going on? I mean, this seems very, very, very fear-mongery, doesn't it? It really does. And there's certainly a bias from the healthcare industry here that they've got here. But, you know, here's the thing. Let's have a talk about this, guys. We got to open up eventually. There's never going to be a perfect time. It's got to happen. We can't keep locking down the economy. We can't keep locking down people. And we've got to realize that nothing is for free. All of these interventions that we have is going to be there's a cost associated with it. You've given people enough time to make their choices, to get vaccinated, to protect themselves how they will. Let them do it. What do you think, everyone? Take care. Watch this video from my HeiseSaysRealPolitik channel, just discussing, well, the impact of Omicron on immunity against Delta. Take care, guys. Have a happy New Year's night, and I'll see you all in the future in 2022. Bye for now.